Hi, everybody. Welcome to the Heilbrunn Department of Population and Family Health's Monday seminars. I'm Terry McGovern. I'm the chair of the department, and am very excited for today's discussion. We obviously are in a very difficult time around reproductive justice. We were all watching and documenting the access numbers go in the wrong direction during COVID. Both the combination of policymakers taking the opportunity to further restrict abortion access or access to contraception, the incredible obstacles that many women, children, adolescents, pregnant people face during the pandemic, accessing healthcare at all. This is particularly acute in the realm of sexual and reproductive healthcare because of these factors, including obviously the Supreme Court's apparent willingness to gut Roe v. Wade. What we're seeing in Texas has really made the issue of access to contraception without impediment more critical than ever. The issues around telemedicine access more critical than ever. Because of this, we joined in the incredibly powerful work that's been going on for many, many years around trying to get over-the-counter contraception approved. We did a letter that 480 public health professionals and activists and advocates signed, urging the FDA to take action as soon as possible. I will let my esteemed colleagues discuss why this should happen, but the letter obviously summarizes the incredible research that has been done, years of advocacy, and simply says, if not now, when, given what's going on. And it is in that context that we'll have this discussion today. I think that many of us feel the need to actually simply protest what is going on with the Supreme Court around this set of issues, but so many of us are actively involved in making sure that people have the access that they need, regardless of what's happening. And all three panelists here today are folks that never are just protesting. They're always doing the work. They're always making sure that that women, children, pregnant people, affected people can get the access that they need. So we're most interested in that ultimately, and that's what this discussion is about. So let me introduce our three panelists. First of all, we have Dr. Carolyn Westhoff, who is the Sarah Billinghurst Solomon Professor of Reproductive Health in the Department of OBGYN and a professor at PopFam here at Columbia University Medical Center. Her work has long focused on improving quality of and access to contraceptive and abortion services. She's published over 200 articles related to the safety and effectiveness of contraception and abortion. As a member of the National Institute of Child Health and Human Development's Contraceptive Clinical Trials Network, she develops new contraceptives using novel pharmaceutical agents. I could go on and on. She is editor-in-chief of the journal Contraception, a monthly publication for the advancement of reproductive health. Dr. Westhoff is a member of the National Academy of Medicine, senior medical advisor to Planned Parenthood Federation, and actually very, very, very much a driving force around the science that dictates an approval in this context. Next, we have Dázon Dixon Diallo, president and founder of SisterSong. She's a recognized visionary and advocate in the struggle for human rights. Dázon and I have been working together since the 80s. She's a proud member of In Our Own Voice, National Black Women's Reproductive Justice Agenda Partnership, In all things, she advocates for reproductive justice in public health, prevention, and programs. Again, I could go on and on. You can't overstate Dr. Diallo's impact on this field. And she has a master's degree in public health from the University of Alabama at Birmingham and a bachelor's from Spelman, where she recently got an honorary doctorate from Spelman, which makes me very, very happy. And next we have Lupe Rodríguez, Dr. Lupe Rodríguez, who is a scientist and an activist dedicated to all people living in full salud, dignidad y justicia, pardon my accent. She's currently the executive director of the National Latina Institute for Reproductive Justice. Born in Mexico City, she emigrated with her family to California to seek medical care for her brother, got a BA in neurobiology from Harvard. She is a self-proclaimed disruptor, passion for change, and she pivoted from science to pursue social justice policy. She also has a long, impressive bio. I am so thrilled to have the three of you today. I want to just begin by asking Dr. Westhoff, why do we need over-the-counter contraception? I'm going to ask each of you to just answer for about 7 or 8 minutes, and then we'll come back to what can we do. Dr. Westhoff.
We need it to be more patient-centered. Women should be able to get the protection they want on their own without having to wait for an appointment, in simplest terms.
Okay, can you tell us a bit about the process and requirements for getting a medication pill approved? What's going on, and why does the current research meet these criteria?
Okay, absolutely, I will. And I guess one thing, looking back to research we've done in our own family planning clinic here with regard to birth control pills, the number one reason women discontinued the pill was because they ran out. And they couldn't get back to get a refill. So I think we have kind of practical on the ground evidence about how useful a switch could be for women. Now, birth control pills were approved in the US and in the UK about the same time, about 1960, and then gradually have been rapidly, in fact, approved around the world. This started out as a prescription product. Back in 1960, almost every drug in the United States was a prescription product. But there is a lot of worldwide variation in how the pill is dispensed, and the US, Canada, and Europe tend to be pretty strict and formal in terms of keeping most drugs as prescription-only items. And but in every one of the European, North American countries, there's a lot of variation in what's available by prescription and what might be available directly over the counter. Many other countries have a category that we don't have in the United States that's called behind the counter. And that means for getting the pill, many other places around the world, a woman can walk into a pharmacy and just ask for the pill, and the pharmacist will sell it to her without ever having to bring in a prescription or have a doctor's appointment. There's a lot of geographic variation. But years ago, I enjoyed on a trip to Juarez in Mexico, walking across the border from Texas, buying some packs of birth control pills, and I might add misoprostol, and bringing them back across the border. It was as easy as that. For OTC switches, over-the-counter switches have become of interest to the pharmaceutical industry, and the FDA has very specific guidance about what sort of drug would qualify. They have a lot of different rules, but these fall into a couple buckets. One is the ease of self-diagnosis of needing it. Well, if a woman knows that she doesn't want to be pregnant and she's having sex, she's done with the self-diagnosing need. So that's a really easy one to fulfill. It's not like any of us will be trying to figure out that that we have some, mysterious illness that requires a lot of tests to diagnose. The need for contraception is easily self-diagnosed. Another issue is whether there's a potential for addiction, and there is no potential for addiction with birth control pills. So that criteria is really easy to meet. Some other issues sound a little bizarre, that the condition should be either self-limited or chronic. And you think, what is that? Well, risk of pregnancy, you could view as either being self-limited or being a chronic condition. But in either case, no matter how you define it, again, a woman can easily tell whether she needs a contraceptive. The rest of the criteria all really have to do with safety. One issue is whether there's long-term data for RX use, for prescription use, and for the pill, we now have 60 years of safety data, huge amounts of lifetime data for women and the safety of using oral contraceptives. There should be a low risk of harm, which in fact we know come from all those long-term studies that birth control pills are very safe. And in particular, they are safe relative to pregnancy. Pregnancy has much higher risks of complications, harms, serious adverse events, and death. So if a woman doesn't want to be pregnant, taking the pill is essentially always safer for her than continuing to have that risk of pregnancy. Although for some women, different contraceptives may be safer for them in particular. Also for an OTC switch, the FDA requires a benefit-risk ratio evaluation. We really do have that. And, in particular, CDC has spent over more than the last decade, a lot of energy in producing an evidence-based medical eligibility criteria. So you can figure out the benefit-risk ratio for women with different underlying conditions. Finally, the number of adverse drug reactions should be known. Again, we have decades of experience, and it should be easy to detect them. And I think that is quite true for birth control pills. About 30 years ago, I was at a meeting in the Bay Area held by the Kaiser Family Foundation about doing an over-the-counter switch for birth control pill. That's how long this idea has been floating around. And there was actually a publication then enumerating why this would be a good idea, and we're still struggling with it. One reason we struggle with it is over-the-counter switches have to be initiated by industry. And I think that the pharmaceutical industry that produces pills is interested in this idea, but thus for a long time, nobody wanted to get there first. So everybody, I think they were all saying, let's have somebody else get there first, and then we will immediately jump in to do the same thing and compete with them. But things are changing a little now, and we will catch up with that. Thank you.
Thank you, Dr. Westhoff. Dázon, over to you. Can you talk about some of the reproductive justice aspects of this issue and why we need this? We can't hear you though.
Yep. Well, because I was practicing my selfie mic check as usual. So thanks, Terry, and thanks, Carolyn, as well. I think first I need to just a tiny disclaimer. Part of my work in being involved in the over-the-counter issue has been as a member, an active member of the Free the Pill campaign, which has been sponsored with IVAS Reproductive Health. And in addition to that, my organization, SisterLove, is one of the few organizations that's directly involved in the most recent study and the research that's going on around access and attitudes with potential end users, especially young Black and brown women in Atlanta and in Georgia. And just in some of the things that we know is that from a reproductive justice standpoint, when you're looking at the overall context of the reproductive justice and the meaning of it, but more importantly, the practical implications and implementation of reproductive justice means we have to continually be expanding options. We have to continually be making sure that whether it's around choosing to have or not to have children, or even whether it's around how we make sure that we're developing our communities and our families in a way that it's more in our control, that we are able to exact our own agency, that we have more power in our own lives to make these decisions about our lives. That's essentially what reproductive justice says, regardless of who I am, is that it's because I, as a human being, and by my human rights, should have the opportunity to make these decisions. I think one of the things that makes this most important for me around in the reproductive justice context is it brings it all the way back. What this opportunity does is bring us all the way back around to the issue of autonomy. And we know we're consistently bearing against the issue of the right to my body, the right to privacy, the right to my own confidence, as well as my confidentiality. And I think that that's why I see at least the free the pill or the over-the-counter opportunity as a core issue for reproductive justice, because it brings the power right square in the hands of the people who need them the most.
Thank you, Dázon. And Lupe, can you talk a little bit about, I know you've been very involved also in the OTC contraceptive efforts, and also obviously doing everything in a reproductive justice lens, but specifically if you could talk a bit about some of the immigrant women and some of the issues around the ACA, that would be great.
Yeah, absolutely. I first want to say that I, agree entirely with Dázon, and at the National Latina Institute for Reproductive Justice, we, follow and work through a reproductive justice framework and really think about this in terms of building power in communities to be able to have autonomy for themselves and their families and their communities. So I think that resonates so much with the way that we approach this work and how we think about the intersecting issues that you mentioned, Dr. McGovern, about immigration and other issues that keep folks from being able to have access to care, and why for us, we know that we need over-the-counter contraceptives so that our community members who face incredible barriers because of these intersecting oppressions and barriers that they face already, keep them from accessing contraception and other forms of healthcare because of the specific way in which we require that folks get this care. We know that our communities, the Latinx and Latino communities, especially face significant barriers to accessing healthcare because of the lack of health insurance. Our communities have the highest rates of uninsured and therefore lack of coverage to care, lack of access to primary care or gynecological care to be able to get the prescriptions, to be able to get the medication. We know that even folks with documentation status who are immigrants face issues like the 5-year bar and limitations to having easy access to healthcare and other programs that allow them to have access to medical care. We know that in particular also in the Latinx communities, we live in geographic areas where many social services, including healthcare, are scarce. And we see that in the rural parts of the Rio Grande Valley where we work at Latina Institute. We see this in other parts of the country where, again, our communities are isolated, where services are scarce, and again, therefore, getting to a provider to get the prescription you need is a barrier. I'll add that in the Rio Grande Valley, there are internal checkpoints in that area in Texas where folks who are, that limit the ability of folks who are undocumented to move around even within their own community. And so that is another added layer of barrier to, again, not having health insurance, not having coverage, having to pay for this care out of pocket, and again, not being able to get the prescription and the sort of FaceTime with clinicians to be able to get this care. Also add that like so many of our communities, even folks who have documentation, also struggle with language and cultural barriers that continue to be pervasive in medical spaces where they try to get access to care, and that not only hinders healthcare access, but it also healthcare literacy, and it makes overcoming barriers around reproductive healthcare access even more difficult for our communities. I think I'll just end by saying, over-the-counter contraceptives would eliminate at least that one barrier about needing to have a prescription to obtain birth control. It would give folks the autonomy to be able to, as Dr. Westhoff mentioned, get the care they need, sort of self-identify as needing this care. And we know, as mentioned, with so many of the border communities that we work with, again in Texas, that they've been, crossing the border to get medication and contraceptives for a long time, because it's easier, because it's accessible, and it should be something that folks can get in their country of residence, that they can get in their communities in an easy way. And again, thinking about the layers and multitude of issues that folks face every day, this is just one less thing that folks should have to worry about in order to get this life-saving care.
That's great. Thank you. One thing that I always is in my mind, we know that the FDA has a very, very difficult job in having to ensure that the safety standards are met. And we also know that it's a very difficult agency to do advocacy around, because there's a lot of complexity. In this case, there was the mention of industry needing to go forward on the OTC pill, but I wanted to just share that one of my early experiences that I know Dázon shared as well was watching the FDA really respond to the HIV epidemic by speeding up access, by creating parallel track. At the same time, I was representing women who were facing requests to be sterilized because they were of childbearing potential before they were allowed in the early phases of clinical trials. And it turned out that there was a guideline that was promulgated after thalidomide saying women of childbearing potential should not be in the early phases of clinical trials. So obviously the FDA has lots of different constituencies kind of advocating for different things. Do you think the reproductive justice communities are able to be heard at the FDA? Obviously, this is a huge issue as we are in this moment where access is really on the decline. Yes, Dázon.
Carolyn, are you going to take that first?
Well, just one thing I want to throw in is that the FDA has been at a lot of these meetings going back for nearly 30 years, and the FDA has repeatedly said they would welcome an application for an OTC switch for the pill. Now, there are a lot of complexities hidden underneath that encouragement, but I don't want anybody listening today to think that the FDA has crossed their arms in a negative way on this switch. I had a lot of people from the FDA come to me to basically say they support this, so both officially and unofficially. Now, Dázon, please continue.
Yeah, well, I think especially now in this post-COVID time, when we're really current COVID time, when we're paying close attention to the FDA processes and the decisions that they have to make, and that people are beginning to understand that the FDA's role really is to pay most attention to safety and efficacy. And if we can go beyond that to why we think that this is actually a doable thing with the FDA, that I think is the core reason that I have a lot of hope. But more importantly, I think that the process for getting to the FDA this time for the OTC process has actually included, or at least incorporated, a lot of the reproductive justice framework as a part of the process, not just as a part of the readings or the writings or even the intentionality that's gone behind the organizing for the FDA. But the fact that when we're sitting around the table with the Free the Pill campaign, and you've got women of color, you've got people who are representing all identities or diversities of women, and organizations that are led by them as well as serving, but they can sit there and argue to make sure that where are the women who are low income and no income's voices in this? That's an RJ consideration that wouldn't necessarily come before. Where are the voices of the people who have different languages, abilities? What about people with disabilities? What about people in the rural community? Where are those voices, and how are we making sure that we're hearing from them what's needed and how that's needed? And that, I think, has come through differently this time, as well as making sure that we're including a lot more young people's voices at the table and within the research and in the studies. If I could just go back to one of the comments I was making earlier, is that the access issue is becoming more clear, not just because of geography, which is really critical, and not only because of income or economical factors and needs like insurance coverage or ability to pay, but what I think this means is that not only in a self-health care construct, which is where the rest of the world is moving, right? Especially coming from the WHO, that the more power people have in people's hands, the more likely they are to take on preventive measures, is that I can have access in my own time, on my own time, in my own neighborhood, at my own pharmacy, and with my own decisions based on the people who are around me that I choose to enact with, including my pharmacist, which I probably have a better relationship more frequently than I do with the clinical provider. So I think that all of these kinds of considerations are a part of the RJ analysis because it's taking into context the community, the environment, the access issue, the diversity of need across diversity populations. And just on the issue around research, Terry, I was also a part, or I am still a part, of the Phases Working Group, which is a body of people that have been working between Georgetown and Rutgers over the last several years to really turn the tide on the inclusion factors for people who are potentially able to become pregnant and inclusion in research. So there's now a whole new set of guidelines that are being taken up by the NIH and that are being taken up by different pharmas in terms of preventive science or biomedical research that are now using some of these phases guidelines as a way to make sure that there's inclusion of potential people who have potential childbearing into the studies. That is a phenomenal shift from where we were with the history of what you're talking about. And it's actually a big win. And if I shift that, when we're looking at where contraception is going in the context of not only being preventive in terms of pregnancy, but having some potentiality of prevention with STDs, namely right now, HIV and herpes, is that there's a whole lot more impetus for things like the phases guidelines to ensure that people are all inclusive and able to determine for themselves what risks and what benefits they weigh their decisions to be involved in a study. So that's, I think, the whole context of RJ and how we brought that. And I'm hoping that that becomes a part of that application in terms of the argument for an approval of an over-the-counter option, simply because we have done all of the work to make sure that the people are represented. And I've missed out my opportunity to say that at the end of the day, what I'm going to fight for no matter what is I want as many options for my reproductive organs as I have for my hair when I walk in my drugstore, when I walk in my grocery store, when I walk in my pharmacy. You know, right now I can get some prescriptions to keep my hair, but I can also buy a whole lot of things off the shelf. And I want the same opportunity with my vagina and my uterus.
Thank you, Dázon. Before we turn to Lupe, it sounds like progress, which we have to be sure to note progress. And I kind of threw that out as an obvious provocative statement, but happy to hear that things have changed significantly. Lupe, thoughts on this?
You know, I agree with Dázon, and I want to lift up just one quick point about you know, what you mentioned about how important it is for the voices of community to be lifted up in all of this, and for that to be a persistent part and consistent part of what the FDA hears. I think particularly with you know, immigrant communities and communities of color that you know, that have for a long time self-managed their care in various ways. That I think is important, right? There's so much data there really about how safe this is, how like, you know, what the efficacy is. And again, a kind of long-standing history of folks doing this themselves, of being able to care for their families this way. And it's just, I think that's really important to bring up as well. And then of course, you know, I think the issue of language, justice and ensuring that that those voices are brought to the fore as well, that there's that consistent connection to communities that don't communicate in English necessarily. I think that's another important part that we think about every day at Latina Institute, just really ensuring that that all of the communications are able to connect with folks like that who are part of our community here in this country.
I think just to note, I had a message that over-the-counter means no pharmacist involvement. Can somebody just say a word about what that would mean if an over-the-counter will be approved? If it were to be approved, how would that change things immediately?
Okay, well, in the U.S., we don't have an official behind-the-counter category, which is so often used elsewhere. We've seen a little bit about how this looks with regard to over-the-counter emergency contraception. There have been a lot of surveys looking at what pharmacies do across the country, and it is a real spread. And I would say there are differences between chain pharmacies and independent pharmacies and how they handle things. Pills come in a tiny pack, and so one thing pharmacies are worried about is what retailers euphemistically call shrinkage. If you have expensive small packs, people will just pick them up. So they've created, which everybody's seen, even for fancy face cream and hair cream, that that there are these special little things. So even though it's on the shelf, you can't necessarily get at it. And a lot of stuff is behind some counter with the cashier or with the pharmacist, which still requires people to have an interaction with somebody else, kind of ruining the privacy piece of this, especially for minors, and perhaps especially in small towns with independent pharmacies. So the idea of this being, just on the shelf, right along with the toothpaste, where you can just grab it, is probably unlikely, because pharmacies in some communities are going to feel very nervous about that. And we have really not seen over-the-counter emergency contraception being so readily available, sitting right on the shelf, even when pharmacies do have it. And these days, more and more pharmacies do have Plan B. And competing brands, but they do a lot to kind of protect the expensive merchandise. And I believe some of the motivation there is just nervousness about the fact that women can have this access on their own. So once we get it approved, there will be work to be done to make sure that it's really available.
I think, if I can come in here, there's three things in that. One is that there's a deeper consideration for people who are under the age of 18 or who are at least of the age of consent for access to contraception, testing, all those kinds of things. And so I think that while it's a great, easy way to think about it, because there's so many different medications that are considered over the counter, like our NSAIDs, painkillers, allergy medicines, all of those kinds of things that also used to be prescriptive at some point. Over the counter and with regard to almost any sexual and reproductive health products is almost a misnomer, because some people assume that over the counter means off the shelf, and that is not what it is. Condoms in communities like where I come from here in the deep South, well, now I'm in the deepest South, sitting here in South Africa, but even in Georgia, there's still condoms and monostat or drugs for yeast infections are still in locked cabinets that you still have to go talk to the pharmacist or talk to a clerk to open the cabinet in order to have that product. Some of them actually are still behind the counter, even if it's not a policy. And so I think that that's something that we have to take into deep consideration. So the youth or the youthfulness is a concern for a lot of the retailers or a lot of the smaller pharmacies as well. The issue of where these sexual health products are kept and how people access those sexual health products is also interesting. Nobody, likes to see people don't like to even be seen shopping for these things, much less having to interact with other people as they're trying to buy these things. But most importantly, which was a huge debate for us, was how we want to make sure that we're democratizing access to an over-the-counter contraception. So people who can pay for it with a credit card or with cash in their pockets, that's not a big issue. But if I'm already dependent on Medicaid, or if I'm dependent on health insurance for the coverage of my contraception right now, especially where we actually have expansion of the Affordable Care Act, and we have people for whom contraception is now free at no cost, basically because of their coverage, this over-the-counter opportunity takes that away. And so there will be, if we're looking at the considerations that we've been through the Free the Pill group, is how do we make sure that there's still the ability to have access through coverage of oral contraceptives over the counter, and not to lose that economic equity that the ACA currently creates for anybody wanting contraception.
Okay, thank you, Dázon. Lupe, do you want to add anything?
Nothing further to add. Just that again, from the perspective of Latina Institute, I think that part about like the democratization, like ensuring that everybody, regardless of ability to pay, has access and is able to get this over the counter care. And I think that question for us also about like having to talk to someone for immigrant communities that we work with, that fear of going places, of talking to people, if you're already afraid of deportation, of being separated from your family, I think that's a really important factor that we think about when we're advocating around this work, that that has to be part of the consideration as well. And language access always rises to the fore for us. Like, to whom do folks have to speak? What is the interaction like? All of that, and being able to ensure that there's equity there and there's connection there, I think is really important for us.
If the FDA were to approve an over-the-counter, it's not going to change the prescription option, is it? That's a question I have, right? If we're worried about the insurance issues around this.
My best understanding is that clinicians can still write a prescription for this. And in general, if it's prescribed, it's still going to be covered by insurance. I will point out, again, using Plan B as an analogy, in New York State with Medicaid will pay for Plan B even when it is purchased over the counter. And the rule is up to 6 times in 1 year. Who knows who made that one up? But women with Medicaid in New York do not need to have a prescription to go get Plan B. Medicaid will still cover it. So, I mean, every single state has their own rules, which makes Medicaid so painfully complicated, but it does mean states have the option to cover this for women with Medicaid, even if they're picking it up on a walk-in basis. But lots of room for lobbying in the future.
And it sounds like
not covered in our Medicaid does not cover, for example, Plan B in our state. So there's serious barriers and obstacles that are put into place when you start talking about public coverage or Medicaid or Medicare, even for those who are disabled. So there are, there's some things where we all consistently have a lot of blue envy sometimes, Carol.
Yeah, well, I think the states that are currently friendly to reproductive health are likely to find ways to be helpful in terms of implementing this. And all those states that are unfriendly to reproductive health are going to remain unfriendly on this issue.
So let's shift into that. I mean, I think it sounds as though this group thinks the FDA, due to all of your work and Free the Pills work and many groups' work, have been more kind of taking a reproductive justice lens on this. So it sounds as though we all agree that we need the FDA to take this next step and approve something. And then it sounds as though there are huge issues around kind of who pays, how we ensure, everybody has access. Clearly, what we're seeing in states that are not friendly to reproductive health are huge access issues, which were compounded by the gagging of Title X and the Muslim ban, and like 20 different policies all converging to really, really make access a problem, not to mention all of the incredibly problematic immigration policies. So I ask you the very hard question of, what do we do now? In this particular climate, for our students who are listening, for the many people around the country who tune in for kind of a high level check-in about what's happening, what do we do now on not just this issue, but the kind of shifting context of possibly losing Roe as a constitutional right, the access issues around abortion that we're seeing in Texas. So hard question, but I think it's the one we know that folks are doing a million different things. So maybe part of the answer here is describing what's already happening, as well as thinking of some of your kind of thoughts about what you wish would happen. So should I start with you, Dázon?
Wow. So, well, oddly enough, my geek ears perk up. And what I think for especially folks who are researchers is to continue to expand and think about what we can research around the absolute benefits. For example, I don't think there's been a lot, and Carolyn can correct me, but I haven't found a lot of really good research that talks about the potential implications for an over-the-counter accessed oral contraceptive to reduce gender-based violence, for example, to give people a better opportunity to make some of these decisions around their pregnancies in private and individually without engaging partners that may be abusive. So that, I think, and also especially where abuses happen in pregnancy. I think that for those folks who have been looking at ways to contextualize public health and reproductive health in general in the COVID era, is to look at the impacts on sexual and reproductive health that COVID has created, or the response to COVID has created, and how the need for an OTC option has actually increased during the COVID era for people who are not able to get out of their homes and access care, or for places where there were reduced hours or reduced access to reproductive health. Simply being able to even DoorDash your oral contraceptives would have been a huge boon. I haven't seen the data yet that comes out about the level of unintended pregnancies that have happened among our young people, whether through, sexual activity that was consensual and voluntary, or through involuntary sexual activity, including statutory, because so many young girls were stuck at home. I know here in South Africa, we have horrific data about the numbers of unintended teenage pregnancies that have gone up just in the COVID time. And having, again, access to something that they could simply purchase in a store may have given us a different outcome. So I think people from a research standpoint should look to that. The other thing I think that people need to do is continue to be educated about it, have conversations with your folks, with your partners, your friends, your coworkers, your co-advocates, your comrades and co-conspirators in the RJ movement, and then tell others and write about it and read about it and share people's experiences in terms of the conversations that they've been having about what this would mean in their lives. I mean, there's people who can influence people with just thoughts about what this means to them, whether it's through social media, whether it's through the blog space, whatever that is. I think the more we increase the conversation about it and elevate people's knowledge, hopefully we'll elevate the consciousness and move it, because we have a broader voice of people who are demanding approval and demanding access.
Lupe, anything to add there? Thank you, Dázon.
Yeah, no, definitely. I think I'll take it on from that point that you just made, Dázon, about getting involved and like talking to your folks, talking to your friends, family, really kind of building on the momentum that you mentioned that we've made and the progress that we've made here. I think specifically when we think about this, we know that so much of the way that we get, the way that we get healthcare in this country is through healthcare coverage, insurance coverage. And so we're thinking also about like, how do we expand the systems that we have in order to cover everyone, in order to cover those folks that I've been lifting up in this conversation who are, who don't have access to healthcare, who don't have access to the ACA, are undocumented folks, other community members who just don't have that access. And, one specific thing that we're working on is the Heal for Immigrant Families Act, which was, reintroduced in the Senate this year by Senator Cory Booker, and in the House by Representative Jayapal and Nanette Diaz-Barragan. And, that bill would extend access to health insurance coverage for immigrant families, regardless of documentation status, really kind of like covering that part of this where we know that, that's an entry point that we lack, and that where we can have that. I think, if we're able to get over-the-counter contraceptives, if folks have some kind of coverage that can help with that, the barrier of money, the barrier of financial issues. And so we know that this is a really integral part of that. I think, one other thing is, well, first of all, I'll finish the statement there that encouraging folks to call your senators, call your representatives about this bill, and really think about like what that means for your communities, and sharing with your friends and family, and kind of putting muster and strength behind that kind of thing. We're also thinking about things like, other issues in the community related to like building power and investing in communities. To Dázon's point about like how as researchers, as folks who are learning to be leaders in public health in our communities, how we integrate and connect with communities and their stories who don't have access to the institutions that we have, who don't have access to the research that we have, and really kind of thinking about how to do community-centered and community-informed research, how to include and lift up the stories of the community members who are experiencing these issues firsthand, how to always kind of centering the needs of the communities that you work in. And, we know at Latina Institute, our work is centrally focused on building power in communities so that they can be at the front and at the fore. And I think these, the connections and partnerships that we can create with you all and the folks that we're mobilizing and build and supporting and building their power in our communities who are organizing there, I think can be a really powerful connection to make change. So inviting you to follow Latina Institute as well to learn more about the work that we do, so that partnership can come together.
Great, thank you. Thank you. Dr. Westhoff, yeah.
I have a question actually for Lupe and Dázon about this. But already at a number of major retailers like Walmart and Target, you can buy pills for $8 a cycle. Now, you'd have to have a prescription to do it. But once the prescription requirement goes away, I believe it will go away. It's not going to go away for all 40 different pills out on the market, because that would require all of those companies to pursue the switch. But I think there will be at least a couple pills. I would expect that for Walmart and Target, it would make business sense for them to get right on that and sell the newly approved OTC products, probably for the same $8 or $9 that they are currently selling Sprintech and Tri-Sprintech. So do you, and that's going to be, I think, useful access for women who are uninsured. But I want to know from the two of you, because this is not a major social change, but just from a purely economic point of view, do you think those $8 a pack pills, OTC at Target and Walmart, is that going to make a difference for the women that we all worry about?
I definitely think it will. I mean, I think one of the things that we think about often is what, that folks should have access to every option that is out there. But certainly, I think having that basic ability to get something, right, like I think is really important. And I think that that's something that I think would be, a good first step for increasing access and for giving folks that option. I know that with some of the communities again that I mentioned that we work with at in the border, they travel to Mexico to get the contraceptives they need, and often have maybe don't have full options, but there is something. And I definitely agree that like, having that in their community is something that could be a great benefit.
Okay, all right. So
I think that helps equalize it, Carolyn, quite frankly. And so, yeah, I absolutely think that if there's not a real big shift in the price between whether it's prescribed or whether it's over the counter, because I don't think that the cost of it is the only thing that is a barrier to whether people are getting the access to contraception. So like you said, if we adjusted for the social context of it, then I don't think that there's going to be that big a difference. My concern is that for the pharmaceutical company that makes this new drug, it will be first in class. And so in some ways, they're going to be able to set a price point. And I'm not exactly sure where that price point is going to be as a first in class drug out the door. And so that's just because I just don't know. I'm sure we could find out from the pharma and say, well, what are you all looking at? And how long, based on the, patents and all of that kind of stuff that this thing is going to roll. Being involved in the HIV drug community, the whole struggle around that, I have very little hope that it's going to come out at the same pricing or cheap as the drugs that are out now that have numerous generic components that go with them. And so that's why there has to be a concern for making sure that the policies to cover all contraception remains the same, regardless of what that price is going to be. So when that's where making it equally accessible over the counter becomes another part of our activism and our advocacy.
okay, all right. Well, yeah, so we have some questions and we're at the question time. I do want to say, just because I was teaching environmental justice this morning and to a bunch of undergraduates, and we have a lot of preliminary evidence that various environmental exposures cause things like heart valve defects in children and have different sexual and reproductive health consequences, right? When you start to think about that whole process for land use being kind of backwards, when there's a problem, that's when we scramble and try to figure out what's the exposure here, right? We saw this in COVID, right? The converging epidemics of environmental injustice and then this pandemic, right? But you have to actually go 20 steps upstream to get to how those land use decisions were made. And community participation is critical, right, in that. So I think that the reproductive justice movement has made tremendous inroads in getting agencies, like political agencies and policymakers, to think about these issues. But it's such an important and revolutionary concept that you should be talking to communities before you do these things. And we shouldn't just be tracking harm, right? And that is something that our students are demanding. We don't want to hear anymore about the pile of disparities. We want to know how to fix it. And I think all the things you're talking about are how to fix it, including infiltrating the upstream discussions in a more effective way. In a sense, you've done that here, but we need to do it in so many other contexts. And instead of public health researchers just documenting the adverse effects, maybe we need to move to documenting how much communities are often shut out of the decisions that then lead to poor health consequences for them. So I think what you're talking about modeling here is really, and have been doing for many years, is really so important. So just to say that before I turn to the audience questions, and also homage to the many students who say, we don't want to hear this disparity stuff anymore. We want to know how to fix it. So hooray. On that note, let me see, we have a question about quality sex education is another access issues. If birth control pills were offered over the counter, what would counseling look like so a patient understands how it works in their body, or if they have contraindications? Carolyn, Dr. West.
Well, on the contraindication side, I mean, the biggest piece of work that has to happen to get approval is to produce a label that communicates these things effectively. I mean, that's a very big challenge, and testing that label. So, you know, there are definitely some women who should not take combination oral contraceptives in particular, but even progestin-only contraceptives. One group with the clearest contraindication is women who've ever had breast cancer. Now, those women are uncommon in the reproductive age group. And I think they all know they're not supposed to take any hormones. But finding women like that to be able to study to see if they understand the label is something that these companies have to get done. They have to be able to demonstrate that the information in the label will be absolutely clear to the women who have absolute contraindications. And I think that's really getting those studies done for label comprehension is the biggest obstacle. But we need women who got medical problems. We need the youngest women. We need women with lower literacy, all to be in studies to prove that they understand the label, because the FDA won't move this forward without that kind of label comprehension. Now, labels are never perfect. What are people going to do, you know, after approval occurs? I'm going to assume they will kind of go to all their usual information sources, their usual free information sources. There's a lot on the web, and we're going to have to see how that goes. I believe the companies that will bring these pills forward, I'm presuming, will have their own websites with far more extensive FAQs and so on for people to get information. But the whole idea of over-the-counter is that you do not need a learned intermediary. You can make the decision for yourself.
Okay, thank you.
The thing is there should be studies on how many people actually read the labels. So the question becomes, you know, where does the rest of the education come from? Where does the rest of the education come from? And one of the comments in the question also was about reproductive education, reproductive health education overall, understanding our bodies and how these things work in our bodies. And if I could give an example of where I think that in addition to the labeling that's critically important from an FDA standpoint, especially, is that from a utility standpoint, is that that's where the community, where advocates, where providers, clinicians have to be able to translate it for people anyway, whether it's in regular sex education programs, as much as it is in any of the work that people like SisterLove and SisterSong and all the other organizations that have been a part of the working group have advocated for. So if I can give a quick example, we just completed a study over the last 2 years on access to medication abortion in Georgia. And one of the most important things that came out of that study was we ended up producing a very short, informative, animated video that really personifies what it means and what it looks like a day in the life of someone accessing a medication abortion. And so those are the kinds of things that I think are going to be as critical as the data and the information that goes into the label, because that's, regardless of what goes on to the label, when it comes down to the end user, it's going to have to be translated more often than not. And I would be remiss if I didn't just give a big shout out to one of our biggest OTC champions, who's Miriam Young, who's been really providing a lot of helpful information in the Q&A as well. And I want to thank her for helping me fill in some of the gaps. So thanks, Miriam.
Yeah, I think that's right on, Dázon. Like, you know, your point about ensuring that community organizations, folks that have been organizing and connecting with community for decades, in many cases, are part of this picture, part of this connection around education. I agree that for, you know, for most folks, even, you know, myself, like I don't read labels. I know that most folks don't. It's just also above our heads. And I think that popular education, things that are comprehensible for folks, different like literacy levels. Again, the issue of language justice is super important, and really kind of being able to get information from a source that you trust, I think, is also a really key part of this. So community members talking to each other, promotores, so like folks who are in community and share information and connect with folks on education are going to be a really key part of how this works and how how that connection happens for our community members. But I'll also just add again what I said earlier about the fact that our communities have been self-managing care for themselves for a long time, and I think that that's another really important part to bring up here, that folks may not in some cases have formal education, but we know our bodies, we know our community members, we know what has worked for us, and we share that knowledge and that information in community as well. And so I think that that's something that's really valuable to lift up here.
Great. Thank you. So we have 3 kind of questions before I let you each say something and wrap up. Do you think the FDA might approve a progesterone only pill first before a combination oral contraceptive? That's kind of hard for you to answer, but I'm throwing it out there. Carolyn, what role might an auto-injector play in expanding access to Depo-Provera as an over-the-counter method? Has any drug manufacturer company submitted an application to the FDA for OTC BC? Those are 3 questions. I invite any of you to answer any of them.
Well, no applications are submitted yet. There are 2 companies preparing applications that are quite far along in the process, and one for a progesterone only pill, one for a combination pill. I think, I'm probably way too politically neutral and naive. I think the FDA is just, if they get the application, they're going to approve it or not on its merits. I still believe they really want to approve something. And if the pop pill gets their application done first, they're going to be approved first. And if the COC gets their application done first, then they're going to get approved first. I don't believe the FDA will be prioritizing one over the other. About self-injection, people on the call may know that Ciana Press is a self-injection system, a very cute, adorable, I'll grab one out of my drawer right now, self-injection system for Depo Sub-Q, and it's approved in, at least 26 countries around the world. The injection system itself is proprietary, and there is in the United States, it's, I'm losing track of which company's which, but the company that is Depo in the United States, I guess it's now Pfizer, does not have access to that injection system. So this complicated. That's just off in a different direction. Women should be able to self-inject. That'd be great if it was over, et cetera. There's a lot of support for that. But for a self-injection system, Pfizer would have to basically start from scratch because they don't have access to the Uniject system. So either they'd need to get access to that system, which costs money, or they'd need to develop and study a new system, which costs money. And my own personal impression is that Pfizer is not sufficiently interested to do that. That's a very long answer to that. So let me yield to others.
Either of you want to weigh in on those questions, any of them? No? Okay. It's okay.
Yep. No,
So,
I think Carolyn covered about as much as we can get to right now.
So I'm going to give you each a minute to kind of wrap up. I just want to say a couple of things. One is in the hopeful lane, we have the biggest class here at Department of Population and Family Health that we've ever had before. And I would put centrally in our mission, reproductive justice. We are creating we're working on a chair in the name of Billy Avery, which would be a reproductive justice professor. And our students are asking the incredibly complex questions that you all are addressing. And so I want you to know that I think people are listening to figure out what they should work on, how they can help. You know, we are increasingly moving into this nuanced complexity area in the kinds of work that we're doing. So that's very exciting. And I thank you all for kind of being such incredible role models of working in complexity and never, ever forgetting to center the people that we're doing this work with. So with that, I'll just ask you each to say whatever you'd like to say as we close out this fascinating discussion in this incredible moment. So we'll go in the same order as before, as we began. Dr. Westhoff, sorry.
Yes, great. Well, it's great to hear everybody's perspectives on this. I think we are, this has been at least a 30-year process of discussion and planning. I think we're getting close, and I think this is a really good time to be loud on this issue and make sure that the FDA and everybody else who's concerned with this is aware that there really is interest and there really is demand. It's also an important time to give some education on this to gynecologists, to family medicine doctors, to pediatricians, to nurses and nurse practitioners, because many of them are not familiar with these issues. And I think all partnerships will work better if we make sure the medical community in general is on board with moving this forward.
Thank you. Dázon. Thank you, Dr.
I concur with Carolyn. I think what's important for us to remember is, as we talk about options, we're also talking about making sure that we are building equity, that we are focused in on dignity and on increasing the agency of people to make decisions that control their lives every single day. That's what we should all be fighting about. It is an issue of human rights. Reproductive justice is rooted in the human rights framework. And so it's important to be able to think about and talk about the racial implications of making sure that an over-the-counter contraception is equitably available and accessible and sustainable. It's important to think about the economic impacts of having access and the social context of having access, as well as the cultural context of being able to engage in your own decision-making, regardless of age, beyond pubis and into the areas of or opportunities to have children. And at the end of the day, it's an issue about your sexual and reproductive rights and just health rights and justice. And so that's why I think this is an important conversation, and why I think it's an important conversation to be echoed and repeated over and over and over until we get this thing through. And then the next level conversation is making sure that people have the access that they need.
Thank you. And Lupe.
Yeah, thank you so much for this conversation. I agree with everything that's been stated, and with the call for folks to speak about this, for folks to engage in this. I think we are lambasted so much with bad news, with things that are going wrong, with the constant sort of retrogression on reproductive rights and health and abortion access specifically. And I think putting our energy into these proactive, movement forward types of work is such an important part of how we get out of where we are in the state of again, going backwards on access and rights around reproductive health care and autonomy. And again, I think lifting up, for me, always the issue of the inequities that exist in our own systems because of documentation status, things like that, things that aren't always at the fore of these conversations, I think is something I call on folks in this conversation to think about in your work, to think about in the way that you're moving forward with anything that you do, and then also engaging with communities that have been doing the work for a long time. I think that I mentioned it before. We have so much knowledge. We have so much that we can teach researchers and others who are doing this work in sort of like larger policy context. We, have the lived experience to share about what is important and how, and what actually are the good solutions for the issues that our communities face and that we face every day. So I think that call to make connections there, to really center those who are most affected by the injustices that we see. If anything, I think that's the last thing I'll say. That I think that if anything, if folks take anything from this, I'd say that, like, really ensuring that you're engaged with the communities that are facing these issues.
Thank you. So I really appreciate all of your extremely thoughtful remarks. I do want to ask somebody on my staff to share. There is a Free the Pill OTC working group conversation tomorrow, and I'm hoping somebody can put that in the chat and people should tune in. I also want to mention that what we're calling a logo-less coalition, the more moral majority is doing a protest. It's not to take away from anything else, but at the Supreme Court when they come back on the 4th. So if people are interested, please reach out. I guess we really, I'm sorry, the over-the-counter working group event is Wednesday. Somebody's just sending me a text, but I'm hoping it gets posted or we can send it out. I think that all three of you are kind of the reason that we should all have hope and not give up and just keep mutating as we go. We now see that we are in, an unbelievable situation, and there's nobody better to rise to this occasion than all the folks you're talking about. So I want to end this conversation on a note of great hope. I always say to people, if you work at the state level, you see what people are doing, don't worry. And for me, I do feel the need to protest that the Supreme Court allowed this law to go forward in Texas. There are moments that just require protest. For me, this is one. So if you feel that way, join us on the 4th, or join anybody anywhere to exercise your First Amendment rights, but also be sure to make sure, if you're able to give money, if you're able to give support, you give it to the people on the ground who are making sure that the people we've talked about don't lose access. And we don't just allow Texas, which does nothing about gender-based violence, which does nothing about access issues, which has openly white supremacist policymaking, that Texas doesn't get to shift the conversation completely away from their failures on all of those issues to completely dominating the entire policy agenda with restricting reproductive health and rights. So we're all in this together. And for that, I feel incredibly hopeful. And I thank you all. And tune in next week if you are able. Our seminar next week will be Dr. Loretta Ross and Dr. Cecile Richards discussing Roe v. Wade. So ought to be good. Anyway, thank you all. Ciao.
Thank you.